Hi, welcome to Bre Science Lab. Today we are going over the flu in honor of flu season. This is the second video in our respiratory system lectures. So let's go ahead and get started. So, the flu, what is it? It's a viral infection by orthomyxoviridae influenza virus, right? This causes an acute respiratory disease. Occasionally, it'll cause more severe epidemics, pandemics, and we have three types that infect humans. We have type A, B, and C. C really doesn't matter; it causes very mild symptoms, so we're not really going to talk about that. But A and B can cause more severe symptoms. A is really fun because it can infect humans and animals. And type B just infects humans, all right? And that's important to note. Nomenclature, when you are researching or writing about a certain flu strain, this is usually the nomenclature you're going to see. So you have the type, the letter type, then you have the animal it was from, so seal, duck, equine, location of where it was, strain number, and the year it was isolated. And if it's type B, obviously you won't have to have a species because it only infects humans. And if it's a type A, you don't have to put a species designation if it was isolated from humans. Okie dokie. Next, let's go over the structure because the structure is really interesting. The genome is segmented into 8 different single-stranded RNAs. So this is a negative single-stranded RNA. This allows for reassortment, which we'll get into that a little later, but reassortment is the reason for antigenic drift and shift and evolution in these viruses. It's enclosed in a helical capsid, and the envelope has hemagglutinin and neuraminidase, as well as a small amount of M2. So these are proteins that are in the envelope and help with attachment, entry, replication of the virus. Now, I told you we were going to get into reassortment, so here's a little bit more about that. It can happen artificially in labs, and we believe how it happens in nature is that when an animal gets infected with multiple types, there's rearrangement, or animal or a human. If they get infected with multiple types of the flu can rearrange and reassort because of those 8 different single-stranded RNAs, and that creates new strains and new changes in functions. Okay. Protein. So this is a little bit more about those proteins we mentioned from the envelope. Hemagglutinin is responsible for the entry of the virus into the cells. It binds to N-acetyl acid or sialic acid, and the neuraminidase liquefies the mucus in the respiratory tract, allowing for easier entry. M2, it's in the envelope in smaller amounts. The other two are the main ones, but M2 is also very important because it functions as an ion channel, and that regulates the pH inside the virion. All right, and here's a picture of the different proteins. Subtypes. So, like I said, there's reassortment, and this sometimes allows for the flu to make small differences in its molecules. So, the big one is when there's differences in the hemagglutinin molecules. There's HA or H1 through H15, and these are just small differences in the subtypes. Overall, they have the same function, right? It's still the attachment. But there's little differences, and that means that our antibodies against one type do not protect us against an antibody from another type. So we have 15 subtypes from that. Neuraminidase structure can also differ. It's not as important as the H1s and H15s, or H1 through H15, because those are more responsible for like antigenic shift, which is like the pandemics. But neuraminidase structure can also differ, and we have 9 subtypes. And with those 9 and 15 different subtypes, there's technically like 135 possible combinations, but luckily we've only found about 30 in nature. And the 3 combinations that circulate in the human population are H1N1, H2N2, and H3N2. So, what's interesting about that is normally you only have one strain circulating in the human population at a time. And then after a few decades, it suddenly disappears and is replaced by one of the other subtypes. Now, in the 1970s-ish, we had H3N2 that had been circulating for several decades. And when H1N1 appeared, we expected the other one to disappear, but it didn't. It stayed. So now we have 2 strains circulating in the human population. We have H3N2 and H1N1. So both are included in the flu vaccine. Kind of crazy that we have both circulating. There's some studies that suggest that this has happened before in the past, but we for sure know that it's happening now. Antigenic shift versus drift. I already kind of mentioned this, but antigenic drift are just small changes in sequencing of HA and NA. But shift are these like major changes that are responsible for the pandemics, okay? And the antigenic drifts are just more epidemics, just the average yearly differences in the flu vaccine and what's circulating, right? Now, antigenic shift is type A, and it's very sudden, but antigenic drift is a little bit more slower. It happens over time. There's smaller changes, and it can happen in any of the types. I just added a little picture of ducks here because ducks are usually the main animals for type A infections. So that's fun. But really, there's lots of animals. There's whales, horses, pigs, birds, all of them can get the flu. Who, when, and how? So anyone can get the flu, but elderly are at the greatest risk of death and complications. But children are most likely to be infected. Anyone can get it though. And when do they get it? Usually January to March. It's the most common respiratory illness of those months. And that is why we get the flu vaccine before January. So they recommend the flu vaccine around, October, no, yeah, October, September. And that way you're prepared in time for flu season. Now, because of the differing seasons between Asia and us, we are very lucky because we get to analyze what strains were circulating in Asia during their winters or our summers and be prepared and formulate our vaccines to match what we think will happen with our winter because it usually follows Asia's. Spread. It spreads via respiratory droplets. Basically, we inhale the virus. The virus infects the ciliated columnar cells of the mucous membrane areas of the respiratory system. And then HA attaches to the salicylic acid receptors. And then M2 comes in, right? It's that ion channel one, and it drops the pH. That drop in pH allows for all 8 nucleocapsids to be released. Okay. Then there's like a 1 4 day incubation period, and you get all your symptoms. Now, this stays in the respiratory system. So there's no such thing as a stomach flu, right? This stays in the respiratory system. But the clearing mechanism is damaged, right? Those cilia, if you watched our first video, the cilia were those finger-like projections that basically catch the debris and pathogens and then push them out like an escalator, okay? Towards the oral pharynx to get out of your system. But this virus is infecting those ciliated columnar cells. So the clearing mechanism is damaged. And also, that damage can initiate inflammatory responses as well, because our body is like, oh my gosh, something's damaged. And they send out these inflammatory responses like TNF alpha, cytokines, all kinds of things. And that can be helpful or it can be harmful. Symptoms. So, how is this different from a cold? Well, it's a little bit more severe, right? A cold, you can probably still go to work. Flu, you're out. You're out, you're on the couch, you're sleeping. You do not feel good, right? You have an abrupt fever. You can have a headache, myalgia, sore throat, a non-productive cough, but you won't have any coryza, which is a runny nose, and you don't have a loss of taste or smell, which is more COVID, right? With COVID-19, you can lose, or SARS, you can lose your smell and taste. Symptoms last about a week, but cough and just your overall feeling, that can last for 1 to 2 more weeks past that. Now, this can result in more severe illnesses like pneumonia, secondary bacterial sinusitis, and Ray syndrome. Ray syndrome, this is just an important note. Anytime a child has a virus, most of the time there are a few exceptions, but most of the time when a child has a virus, you cannot treat them with aspirin, okay? Because that puts them at risk for Ray syndrome, which is edema, brain edema, liver problems. It's an emergency. It is not good. So generally, you do not give aspirin to children with viruses. There's a few exceptions, but that's general. And for some reason, it we see this more with type B flu, but it can happen with any. Antiviral treatment. This is not a bacteria. This is a virus, so you do not give antibiotics, right? That can even be harmful because it can cause resistance in the community. And antiviral treatment is available, right? It's more so for individuals at greater risk or if they have a higher potential of spread to those at risk. So you're living with elderly family members or you are immunocompromised, something like that. And right now, we usually use neuraminidase inhibitors because they work against type A and type B. These are just analogs of sialic acid, but this can reduce duration and severity of symptoms. Now, there's no research showing, hey, this reduces, fatal problems like pneumonia down the road and stuff. It really is just reducing duration and severity of symptoms right now. This is the most common one. Brand name is usually Tamiflu, but oseltamivir is a generic name, and that's usually what you have to know if you're in pre-med or med school. It's the most commonly used one. It's oral. It's just has to be given within 48 hours of symptoms, okay? But this is what's used usually in hospitals, pretty much any setting. Now, zanamivir is a common alternative medication. It's an option. It's inhaled though, and so obviously that comes with more contraindications because you don't want to give that to someone with asthma or COPD. But there's other contraindications for that, and that's between an individual and their healthcare provider. But again, it's usually within 48 hours of symptom onset. Amantadine and Romantadine, if that sounds familiar, that's because that's what we used to use, and those are inhibitors of the M2 ion channel, so it blocks that ion channel. It's no longer used though because it doesn't work against type B, and rapid drug resistance emerged from type A just rapidly. And it's also a teratogen, so you can't give it to pregnant women. So we really don't use those. Vaccines. Okay, in honor of flu vaccine season, let's go over these. These are recommended usually between September and October, and there's different types. There's the live attenuated influenza vaccine, as well as the quadrivalent and trivalent inactivated influenza vaccines. So, trivalent versus quadrivalent, that's just saying how many it is protecting against. And it just depends on what's circulating. So I believe in this season, 2025 to 2026, it went back down to trivalent, but for the last few years, it was quadrivalent. I think they were recommending trivalent because the type B that was added was no longer really a big problem. Now, inactivated influenza vaccine, you can't get the flu from that. Live attenuated influenza vaccine, that's a live one, so there's a risk, which means you don't give it to pregnant women or immunocompromised patients. Now, the vaccine makeup changes every year because the flu changes every year because of that antigenic drift we were talking about. Now, both type A's that are circulating in the human population right now, those are both included, as well as a B, sometimes two B's. And the inactivated killed virus is intramuscular. It's also grown in eggs, so there is a potential allergy contraindication that you should be aware of. Now, these are just rough guidelines. These aren't recommendations from me or anything. This is just rough guidelines are healthy individuals between the ages of 2 and 49 years should receive the live attenuated influenza vaccine. There's some contraindications that we already mentioned, immunocompromised, pregnancy. Now, the inactive is for anyone that can't have the live attenuated one and 6 months or older. Elderly may require additional doses, so there is a high dose and an adjuvanted dose available, and that is between an elderly patient and their provider. Thank you very much. And if you have any questions, please comment them and stay tuned for our pneumonia lectures. Thank you.